Okay, so we are going to pick up where we left off. We were talking about the granulocytes. They were the classification of leukocytes or white blood cells that had granules that were located in the cytoplasm, and they had lobed nuclei, and they included the what I refer to as the fill family. They were made up of basophils, eosinophils, and neutrophils. So now we're going to talk about the other grouping of leukocytes, which is the agranulocytes. And within the agranulocytes, we have two main types of cells. We have the lymphocytes and we have the monocytes. So the first type of agranulocyte we're going to talk about is the lymphocyte. And there are three major types of lymphocytes. The first one is the natural killer cell, or the NK cell, which if my son can hear me in his room, his natural killer cell is his favorite name for a white blood cell. It is kind of very dramatic, natural killer cell. Lymphocytes, another type of lymphocyte are the B cells or the B lymphocytes, and also the T cells or the T lymphocytes. And when we talked about leukopoiesis, or the formation of white blood cells, we said that the difference between the B lymphocytes and the T lymphocytes is where they are going to undergo maturation. The B lymphocytes undergo maturation in the bone marrow, hence the B in the B lymphocytes, where the T lymphocytes are going to undergo maturation in the thymus, which is a gland that lies over our heart, and hence it has the T for thymus, so T lymphocytes. The first type of lymphocyte is the natural killer cell, or NK cell. So the natural killer cell is going to provide a generalized, non-specific immunity. So the reason why this is called the natural killer cell is because it is just going to kill anything that's there. Anything, any type of cell, shall we say, let me put my laser pointer on, any kind of cell that it comes in contact with that does not express a self-surface protein. So a cell-surface protein, all of our cells that belong in our body produce or have on their surface of the plasma membrane kind of an ID tag, a self tag that says, hey, I am Miss Roche's liver cell. I am Miss Roche's red blood cell. I am Miss Roche's brain cell, so that it can be identified as self, or be identified as belonging in the body. This is important because it makes it very easy for your immune system to distinguish what cells belong in Miss Roche and identify as self, and those which do not. Those which do not have this self-surface protein are going to be targeted to be taken out by the immune system. And so I was speaking of him, he's trying to quietly walk into the kitchen, in the dining room. He's very excited because he heard that I was talking about natural killer cells. Okay, so the natural killer cells, basically, they're just gonna roam, he hates me, by the way. They're just gonna roam around the body, and any cell that they come in contact with that does not have this self-surface name tag on it, they're gonna immediately take it out of commission. So any kind of cell that contains foreign or abnormal markers are going to be taken out. And the reason why it's called a natural killer cell is because the other lymphocytes, the B cells and the T cells, are going to also take out foreign particles and abnormal cells, but they have to kind of be helped a little bit. They have to be told, hey, we're pretty sure that cell over there doesn't belong in here. Can you go take care of it? Where a natural killer cell, just nobody needs to tell them to do their business. They just go out and they just, obliterate whatever is not recognized as self. The second type of lymphocyte is called a B cell, or a B lymphocyte. And as I said, it's called that because it matures in the bone marrow. Bone marrow starts with a B, hence B cell or B lymphocyte. So the B cells or B lymphocytes are involved in what is referred to as specific immunity. And this is very different than the non-specific immunity that the natural killer cells take part in, because in specific immunity, there are going to be specific targets. They're going to be involved in a type of immunity that doesn't just kill all foreign cells, regardless. They are going to only be involved in killing certain foreign cells. And it's these B lymphocytes that are going to be responsible for producing something that is in the news a lot lately because of COVID, antibodies. So B cells will differentiate or produce cells that are called plasma cells when the body is infected with a foreign particle. And these plasma cells will then be responsible for producing antibodies. And these antibodies are what our body makes in order to recognize a specific invading or foreign particle in the future. And the way the antibodies work is that when they come in contact with this specific foreign or abnormal component that is on the plasma membrane of a invading cell, it will bind to it and kind of put a tag on it, or kind of put like a hit out on it. So let me explain this a little bit. So in the case of a COVID vaccine, all right, so you go to get your COVID vaccine, and they are going to, or any kind of really vaccine, the way that vaccines work is, in general, they're going to give you some sort of protein that is located on the surface of that particular virus. So in the case of the COVID vaccine, they're actually giving you some mRNA, and that mRNA is going to be used to make a protein that is found on the exterior of the COVID virus. So once this foreign protein starts floating through your, is in your body, these B cells are going to, kind of notice, hey, there's something foreign here. This thing doesn't belong here. So the B cell will then produce a plasma cell, and that plasma cell will produce a specific antibody that is generated just for that foreign COVID protein. And that antibody that is produced will remain in circulation. And anytime that antibody comes in contact with that specific COVID protein, the antibody binds to the COVID protein. And when the antibody binds to the COVID protein, it is kind of a signal to the immune system as, hey, this guy invaded us before, and it wasn't good. So here, take this guy out of circulation. So that's what an antibody is. And so this is referred to as more of a specific immunity, because unlike the neutrophils and unlike the natural killer cells, that it doesn't matter what you are, if you're foreign, we're just going to take you out. The lymphocytes, the B lymphocytes, only are going to work on, or the antibodies that these B lymphocytes produce are only going to work against one specific type of proteins. So as a child, you got lots of vaccinations. So your B lymphocytes were very active, because when you got a shot for measles, your B cells produce plasma cells, which produce antibodies specific to the foreign particles of measles, a measles virus. Same thing with chickenpox, specific antibody for the chickenpox virus. Mumps, specific antibody for the mumps virus. So this, you might say, well, why don't we just have the cell that the natural killer cells that just take out everything? Why spend this time producing antibodies for specific individual foreign invaders? Well, because once your body develops antibodies, well, now if you were to get infected by COVID, or you get infected by the measles virus or the flu, influenza, your body already has these antibodies in circulation. And before the virus gets a chance to invade your cells, and before you get those symptoms of being infected by that virus, the antibodies have already jumped into action and taken it out. So in essence, if you get a vaccine, it doesn't prevent you from getting infected. It prevents the virus from lasting in your body long enough to cause any sort of symptoms. And you say, what do you mean? I can still get infected with COVID? Well, the virus can still get in your body. I mean, the vaccine doesn't like produce an invisible protective shield around you. You can still get the virus in your body. It's just that the antibodies are going to kill that virus before the virus has enough time to infect your cells to a point where you actually start to exhibit symptoms of that illness. The other type of lymphocyte is the T lymphocyte, and we call it the T lymphocyte because this is going to mature in the thymus, hence the T. The T lymphocyte is also involved in this specific immunity. So T lymphocytes are going to attack specific foreign cells. And so they, these T lymphocytes are going to be what are responsible for killing the foreign bodies that have been tagged with the antibodies. So again, the T lymphocytes and the B lymphocytes are going to work hand in hand for this particular specific immunity. And we actually have an entire chapter that talks about immunology. So we'll go into this in a little bit more detail when we get there. But it's important that you know what we're learning right now as we are learning about these particular white blood cells. So if you go to the doctor and they take your blood and they look at the individual white blood cell counts, and you have a high level of lymphocytes in your circulation, it is a good indication that you have some sort of viral infection, because that is what these lymphocytes are going to be involved in combating. They're involved in finding foreign viral proteins, producing antibodies for them, and then of course taking them out once they've been tagged with these antibodies. Also, if you have a high number of these lymphocytes, you also can have certain types of cancer. As I mentioned before, your immune system is built to attack cells that are more prolific than they need to be, or reproduce faster, or have some sort of genetic damage. Of course, some cancers are stronger than your immune system, and we're working on, scientists are working on that, doctors are, medical doctors are working on that, and involving and creating new drugs that actually boost your own immune system to fight cancers. It's becoming, they're called immunology cancer drugs, and they are very highly effective. And because they target specific cancerous cells, they actually have a lot less side effects than your traditional chemotherapies. The last type of leukocyte we're going to talk about is also in the agranulocyte grouping, and these are the monocytes. So monocytes originate from the myeloid cell. The only white blood cell that does not originate from the myeloid stem cell was the lymphocytes. They originate from the lymphoid cells. They have a very large, abundant blue cytoplasm. They have a horseshoe-shaped nucleus. Monocytes are macrophages. Sorry about this being dotted. This is actually one concept. I don't know why there's, I messed up. There shouldn't be a dot and a bullet point here and here. So macrophages are phagocytic monocytes. So remember, a phagocytic cell is a cell that is going to engulf and kind of like eat another cell. So when the monocytes are going to leave circulation. They become macrophages, and they will engulf debris that they find, any kind of pathogens, dead, worn out, damaged cells. They kind of are the, let's say, the trash compactor of the body. They are just constantly cleaning up refuge in the tissues. The way that monocytes are also going to work is that they have the ability to release antimicrobial defensins. So defensins is a type of chemical that you can find in the monocytes. They release these defensins and will kill any of the microbes in the interstitial tissues or interstitial fluid in the tissues. And when they're doing their work, they're also going to release chemotactic chemicals. And I talked about chemotaxis. Chemotaxis is the kind of like a chemical signal that is going to cause other white blood cells to come to that particular area. So they send out this kind of like homing signal in the form of a chemical. And these homing signals, these chemotactic chemicals, are going to attract more white blood cells to a general region. It's very effective because, say you have a lot of debris, dead, worn out cells, or pathogens or bacteria in a particular area. Well, if one monocyte finds its way there and detects that there's a lot that needs to be engulfed, well, it starts doing its job, but it's not going to be able to do its job all by itself. So it sends out these chemotactic chemicals to invite all of its friends to the party so that more monocytes are attracted there so the job can be done more swiftly. And of course, as more monocytes arrive, those monocytes are also going to release chemotactic chemicals. And it's kind of this cascade of events that draws more and more white blood cells to the region. So if you have a high count of monocytes, it's an indication that you have some sort of viral or fungal infection. And you also can have a high monocyte count if you have a chronic disease. The difference between a chronic, and you may have heard of an acute disease. An acute disease is something that comes on, like the symptoms come on very fast, then it's, diagnosed, you're cured, and then that's it. Someone that has a chronic disease is a disease that just lingers and lingers and lingers. Normally it's diagnosed, but those symptoms just go on and on and on and on and on before you finally are relieved of it. You think of something like the common cold might be an acute disease where, you get really, really sick, you feel like crap, you take your medicine, a couple days later, you feel better. Something that might be considered like, well, this isn't actually caused by any kind of like bacteria or something, but someone who has something like arthritis might be suffering from a chronic disease. It's something that's going to last for a very, very long time. In the case of arthritis, probably for the remainder of their life. So chronic means long-lived, acute means very quick, here, very quick, gone. All right, the next type of cell that we're going to talk about, I'm going to open this over here. Next type of cell that we're going to talk about is the last one in our formed elements, and that's the thrombocytes. So the technical term for our thrombocytes are our platelets. So technically, thrombocytes aren't an entire cell. If you remember when we talk about thrombopoiesis, we said that hemopoietic cell differentiated into a myeloid stem cell, which differentiated into a megakaryoblast, which differentiated into a megakaryocyte. The megakaryocyte underwent mitosis, and it underwent mitosis. It didn't undergo cytokinesis, so it just got larger and larger and larger. And eventually, little fragments of the cell plasma broke off, and it's those little fragments that broke off that megakaryocyte cytoplasm that is actually the thrombocytes. So here we have an image of some blood. So of course, these are our red blood cells. You can see there's a little bit of a clear look to the center of it because of the biconcave shape. This large guy right here is a lymphocyte. It's got a large round nucleus, a little bit of that blue cytoplasm. And then we see all of these little tiny fragments of dark, purple amongst everything. Those guys are our thrombocytes. So even though they're small, they have a very, very, very important job. They're going to be essential for hemostasis. And hemostasis is the stoppage of blood flow following damage to a vessel. So that's a very fancy way of saying when you cut yourself and you start to bleed, the thrombocytes or the platelets are going to be responsible for stopping the bleeding. Again, pretty important, because I don't know about you guys, I'm pretty clumsy, cut myself a lot. If I didn't have these thrombocytes, I would have been dead years ago because I would have bled out just based on little tiny cuts that I have from, working with things. These thrombocytes are going to be able to stop the blood by producing what is going to be referred to as a platelet plug that we'll learn about in a few minutes. But beyond just stopping the blood flow at damaged vessels, they also are going to help by producing growth factors that will actually heal and help repair the damaged vessel and also the surrounding tissues. So thrombocytes are going to circulate in an inactive form, and that is really a good idea because if their job is to cause, blood clots essentially, you don't want them just flowing through the bloodstream, just able to form a blood clot whenever, they want to. Because even though blood clot formation is very important, if we have a damaged vessel to prevent us from bleeding, completely bleeding out, the formation of blood clots inside a vessel, not a good thing, because that can lead to blockage of a vessel, which is what happens in the case of stroke. A stroke would be a blockage of a blood vessel in the brain, or a heart attack, which is the blockage of a vessel that supplies blood to the heart muscle itself, or a pulmonary embolism, which is a blood clot that prevents blood from getting to the lungs, so you don't get oxygenated blood. These are all very bad things that you do not want to happen. So to prevent these thrombocytes from just, producing unwanted or, very dangerous blood clots whenever, they are going to circulate in an inactive form, which when there is damage to a vessel, they will be activated and they will form blood clots when it is proper to do so. About 1/3 of the thrombocytes that we have in circulation at any point in time are going to be stored in the spleen and, of course, released when necessary. All right, so we talked about the thrombocytes and the fact that they are responsible for hemostasis. So let's talk about what hemostasis is. How do your thrombocytes repair or stop the blood flow from a damaged vessel? And how are they going to help repair that vessel? So hemostasis, again, is a process by which the body seals a ruptured blood vessel and prevents further loss of the blood. And it can be described in 3 distinct steps. The first step is the vascular spasm, or sometimes it's referred to as vasoconstriction. And vasoconstriction just means, vaso means vessel, constriction means if you constrict something, you make it tighter or smaller. So vasoconstriction means, a constriction of the vessel. The second step is formation of a platelet plug. And in the formation of a platelet plug, we're going to see those platelets are going to cause a, I hate to use this, if anybody's ever like seen drywall, you know, or fixed a hole in the wall, you have like that spackle that you spackle over it. That's what this platelet plug basically is. It's just like platelet spackle over the opening to stop the blood from escaping the damaged vessel. And then the formation of the platelet plug is going to be followed by coagulation. And in coagulation, we're going to have a clot formation where the platelets are going to be replaced by some proteins that will remain in place as the tissue in the vessel actually regrows and repairs the opening. All right, let's start by talking about this vascular spasm. So this is a blood vessel. So in the blood vessel, what we have, and we'll learn about this in our next chapter, we have this interior layer called the endothelium. We talked about the endothelium in 201. It is a type of tissue called epithelial tissue. Epithelial tissue is a lining type of tissue. If you don't know that right now, it's okay. Do remember that the interior lining of a blood vessel is called the endothelium. And we'll actually talk about the endothelium again when we talk about the heart and we talk about the blood vessels. So we have this inner smooth lining called the endothelium. And then we have some basement membrane. And then on the exterior, we have smooth muscle. And this is what's going to be involved, this smooth muscle, in the vascular spasm. So the smooth muscle in the vessel wall, when there is injury to the vessel, is going to constrict. It's going to tighten the vessel. Now, why would you want to do this? Well, what happens if someone cuts themselves and, you've seen it in movies or hopefully not in real life, but if you have, if someone cuts themselves really bad and their like legs bleeding, what do? Like, they put on a tourniquet, right? Why are they putting on a tourniquet? Well, they want to stop blood flow to that area, because if you stop blood flow to that area, you're going to stop the blood loss from the damaged vessel. Well, the vessel itself is doing a little bit of this tourniquet work too in this vascular spasm. So the muscle and the smooth muscle in the vessel wall is going to contract. And as it contracts, it's going to slow the blood movement into that vessel and slow the blood movement to the damaged area, thereby preventing blood loss. Now, the smaller the vessel, the better this vascular spasm is going to work. So for instance, if you cut your finger and you have a little bit of a small vessel there in your finger and it's bleeding, the vascular spasm is probably going to do a pretty good job at slowing the blood rate to your finger. If you were to cut your femoral artery, a very large artery, that vascular spasm is probably not going to be very good. It still happens, but that's just too large of a vessel and there's just too much blood flowing into that vessel for the vascular spasm really to be adequate to stop blood flow to that area. So even though the vascular spasm is very beneficial, the smaller the vessel, the better. The larger the vessel, the more screwed you are. That's when you really want to make sure you have a tourniquet in place there. So what is going to trigger the vascular spasm in this damaged vessel? Well, it's going to be triggered by chemicals that are called endothelians. Well, what do you think releases the endothelians? Well, it's the endothelium. So that's cells that are going to line the interior of our blood vessels are going to release this chemical called endotheliums. This chemical is released by the endothelial or vessel lining cells, and also by pain receptors in the vessel itself. And it's going to trigger the constriction or the vascular spasm at the particular site of injury. Our next step is the formation of the platelet plug. So we have these platelets that are in circulation. They are circulating in an inactive form. And platelets really like smooth sailing. They really like to just glide along the blood vessels. And the blood vessels, because they are lined by the endothelial tissue, which gives a very smooth coating to the interior or the opening or the lumen, what is called, of the vessel. The platelets are always very, very happy because they just slide right by. You know, like when you're driving on a newly black-topped road and your tires are just, it's just, you know, smooth sailing. What the platelets don't like is when there is a roughened area that they come in contact with. So imagine you're riding down a newly paved road and all of a sudden it becomes the original, you know, ubiquitous in Alabama cement road that when you're riding on it, it goes, you know, your wheels are like, you know, chattering and, you know, not very smooth riding. So your car doesn't like that. Well, your platelets don't like that kind of situation either. They don't like to go from a very smooth sailing interior of a vessel to a very rigid, rugged, kind of rigid portion of a blood vessel. Now, when a vessel is damaged, what happens is that the underlying collagen fibers or the protein fibers that lay underneath the smooth endothelial lining become exposed to the interior of the vessel. And the collagen fibers are very prickly, you know, they stick out kind of like the bristles of a brush. And when the inactive platelets kind of glide by these bristly kind of collagen projections, they get stuck. You know, they're not going to be able to just slide by. And as they get stuck, they start to clump together. And this is what's going to form this platelet plug. Now, there are certain proteins that are in circulation in the blood plasma that are going to help stabilize the platelet plug and also enhance the formation of this platelet plug. One of them is called the von Willebrand factor. Mr. I guess von Willebrand discovered this. And this glycoprotein is going to kind of piggyback on top of these platelets that are getting stuck on this exposed collagen fibers. And it is going to help stabilize the platelet plug. And I have a picture on the next slide. And these von Willebrand factors attached to these clumping platelets are going to help form this nice bridge-like structure that is going to span the damaged vessel. Now together, the accumulation and adhesion of the platelets at the site of the blood vessel injury is referred to as a platelet plug, and I've mentioned that a couple of times already. So let's look at this here. All right, so here we have our interior of our blood vessel. So we have our smooth muscle here on the outside, then there's underlying collagen fibers, and then on the interior of the vessel, there's these endothelial cells, very nice and smooth. So normally what we would see is the platelets, smooth past these nice, slick endothelial cell lining. Now, when the vessel is damaged, these underlying collagen fibers are going to be exposed. So when the platelets go through, they're going to get stuck on these exposed collagen fibers. And as they get stuck, they are going to start to clump together. And we're going to see that also what's going to come into play are these von Willebrand factors, which are going to help make this platelet plug bridge or form this bridge across the area of the vessel that is damaged. Now, not only do the von Willebrand factors help in forming this platelet plugs, but when the platelets themselves get stuck, they are going to release chemicals that are going to further the activation of other platelets and attract more platelets to the area, kind of like the monocytes did with the chemotaxic chemicals. It's going to be this positive feedback mechanism where more and more platelets are going to be called to the area until we have this entire area covered with this platelet plug. One of the chemicals that the activated platelets are going to release is ADP, and we've talked about ADP before, but it was always in the case of ATP and ADP, or some sort of energy providing chemical in the cell. Well, in this case, it's the same thing. It's adenosine diphosphate, but it's not acting as a energy molecule, but it's going to help adhere additional platelets to the injury site. And it also is going to reinforce the platelet plug. And as I said, this is going to be a positive feedback mechanism where that signal is going to increase until finally homeostasis is brought about, and then the signal will stop. Other chemicals that the platelets are going to be released to contribute to the homeostasis of or the blood platelet plug formation is going to be serotonin. Again, you may have heard of serotonin. We hear of that a lot in, it's like the happiness neurotransmitter. You know, the people who have depression have low serotonin counts. If you take an antidepressant, it's supposed to up your serotonin levels. But just like our epinephrine and our norepinephrine that acted as a neurotransmitter, but also as a hormone, serotonin can act as a neurotransmitter and also as a chemical signal healer. And in this case, the serotonin is going to help maintain the vasoconstriction of the vessel. Also, we have chemicals called prostaglandins. Prostaglandins are also going to maintain vasoconstriction and also activate further clotting chemicals. And we'll talk about the clotting chemicals when we talk about, the coagulation. And here we are. So our last step of hemostasis is coagulation. So coagulation is defined as the formation of a gelatinous clot made up of a mesh of fibrin. Now, we talked about a plasma protein when we talked about the plasma called fibrinogen. And fibrinogen is going to be the precursor of fibrin. So fibrin, which is going to form this fibrin mesh, which is going to be the base of a blood clot, is an insoluble filamentous protein that is going to be derived from fibrinogen, which is in our blood plasma naturally. And within this protein, blood cells are going to be trapped and form this blood clot. And the process of coagulation is also often called, the coagulation cascade, because it involves a lot of different clotting factors. And I have this here, don't freak out, you're not going to have to reproduce this, but there are numerous clotting factors. Here we have 12, 12A, 11, 11A, 9, 9A, 10, 10A. 8A8. We have 13 over here, 1, 1, and 2. They are listed out of order because the clotting factors were actually discovered and named before we knew what they did or how they acted. So it was one of these situations again where they were named according to the order in which they were found, but not in which the order in which they actually work. So this whole thing is a big cluster when you look at it, but don't worry, I'm not going to make you learn this sort of thing. If I did, you just forget it immediately anyway. So why take up the space in your brain at this point in time? But I do want you to know that it's referred to as a coagulation cascade because one event is going to trigger another event, which triggers another event. And eventually, no matter how the cascade starts, we're going to end with the same result. The same result being that the inactive plasma protein fibrinogen is going to be converted into the active protein fibrin, and it's that fibrin that's going to form a mesh in which the coagulation is going to occur. Oh, well, I just said this. So clotting factors, there's 12 different clotting proteins that react within this coagulation cascade. They're numbered from 1 to 12, but again, they're ordered in the number that they were discovered, not in the order of their sequence. So for instance, this pathway starts with 12, this pathway starts with 7. They both go through this cascade ending with factor 10. And fibrinogen is a factor 1, so it's totally not in order. That happens a lot in science where they figure out that something exists and they number them, and then years later they find out, oh wait, they don't work in that order at all. But by then it's too late, and they don't want to renumber them for confusion sources cases anyway. I don't know, it's just messed up. Sorry. So in coagulation, there are 2 separate pathways. This one looks a lot simpler than the one that is before, but essentially it's the same thing. It's just without all those extra arrows. So we have 2 pathways. We have the extrinsic pathway and we have the intrinsic pathway. And basically what the difference between the two, the main difference between the two, is that the extrinsic pathway is going to begin outside of the bloodstream. So you can think of exit is, starts with EX. So extrinsic means outside. So you take an exit to leave or go outside. So the extrinsic pathway is going to begin outside the bloodstream. And because it begins outside the bloodstream, it's going to be triggered by external damage to extravascular cells. Extravascular just means outside the vessel cells. So damage in the tissues. The other pathway is called the intrinsic pathway, and the intrinsic pathway is going to start inside, IN, the vessel. So the intrinsic pathway begins in the bloodstream, and it's going to be triggered by internal damage to the vessel wall. Now, regardless if this cascade event started with the extrinsic pathway with damage outside of the vessel, or the intrinsic pathway with damage inside the vessel, both of these are going to converge into a pathway that is called the common pathway. And so the extrinsic pathway leads to the common pathway, the intrinsic pathway leads to the common pathway. And it's the common pathway that is going to end with the conversion of the inactive fibrinogen into the active fibrin, which is going to be responsible for forming the blood clot. All right, we're going to go over these pathways, and then we're going to be done with this lecture, and we'll have one more about blood typing for this blood. But all right, so extrinsic pathway is going to be triggered by external damage. It is a quicker responding pathway, and it's more direct. It begins with damaged extravascular cells, and these damaged extravascular cells are going to release a chemical that's called the tissue factor. Now, there is another name for the tissue factor. It's called thromboblastin. Let's just go with tissue factor. It's easier to remember and a whole lot easier to pronounce than thromboblastin, okay? So, damage to the tissue outside of the vessel, cells release tissue factor. The tissue factor is going to go through, this cascade of events where there's different clotting factors that are going to be produced. But eventually, this whole entire cascade is going to lead with the activation of clotting factor X. If we look at the intrinsic pathway is longer and more complex. You can see that there is a lot of different clotting factors that are involved in this. Again, remember the intrinsic pathway is going to be triggered by damage to the blood vessel itself. The intrinsic pathway is going to begin with the activation of clotting factor 12. Clotting factor 12 is also referred to as Hagman's factor. Good old Hagman discovered it. But we're just gonna go with the 12. You don't need to know all these guys' names. I found them, whatever, it's 12. So it begins with factor 12. Again, it's going to go through several different types of activations of different clotting factors, but as I said before, the end is going to be the same. It's going to be the activation of clotting factor 10 or clotting factor X. All right, extrinsic, outside damage, tissue factor, factor 10 or factor X. Intrinsic pathway, internal damage, starts with factor 12, ends with factor 10, or factor X. Now, regardless if we got here to this common pathway through the extrinsic pathway or the intrinsic pathway, the common pathway is only going to proceed one way. All right, so both the intrinsic and extrinsic pathway leads to the common pathway. The common pathway is going to begin with the activation of factor 10 or factor X. What is going to happen after this is that an inactive enzyme that is in circulation at all times called prothrombin is going to be converted into an active enzyme called thrombin. So prothrombin is basically means, like a early form of thrombin. So the prothrombin is an inactive enzyme. Factor 10 is going to cause prothrombin to be converted from its inactive form into its active form, and it's going to become the active enzyme thrombin. The active enzyme thrombin is then going to convert the protein fibrinogen, which is inactive and in our plasma at all times, into an active form called fibrin. It's this active fibrin that is going to form the fibrin mesh that is going to trap the blood cells and form the blood clot. Okay, so very quickly. Intrinsic pathway, interior damage to the interior of the vessel, starts with factor 12, ends with factor 10. Extrinsic pathway damage to the exterior of damage to the tissues, starts with the tissue factor, ends with factor 10. Common pathway starts with the activation of 10. 10 is going to convert the inactive enzyme prothrombin to the active enzyme thrombin. The active enzyme thrombin is going to convert fibrinogen into fibrin, and it's this fibrin which is going to be the mesh-like structure that is the base of the blood clot itself. Now, the fibrin forms a very fine mesh, and it kind of acts like a colander, you know, when you're like draining pasta. So the colander portion would be the fibrin, and as the blood cells pass by, the fibrin mesh or the colander is going to catch all of the blood cells, the white blood cells, the red blood cells, the platelets. And just like when you pour pasta into a colander and the pasta, fills the colander, it's going to, if you put too much in there, it's actually kind of hard to drain because the pasta will kind of cover up all of the holes. Same thing with your blood cells. As the blood cells pass by this fibrin mesh, it gets caught in this mesh and it kind of plugs up the hole that is formed by this damaged vessel and prevents further blood from being lost. However, we've officially completed our hemostasis because we have stopped the bleeding of the vessel, which is what the hemostasis is. Well, we really haven't repaired the vessel itself. And the repair of the vessel is going to begin with a process that's called fibrinolysis. And during fibrinolysis, lysis means the removal of or the breakdown of. And so essentially fibrinolysis means the breakdown of the fibrin. It's going to break down this fibrin mesh. And as it's breaking down the fibrin mesh, it's going to replace it with new vessel cells. So what we see is that there are actually contractile proteins within the platelets, actually the same exact contractile proteins that are located in our muscles. And these contractile proteins are going to, once the blood clot has formed, are going to start to contract. And as they start to contract, they're going to pull on the fibrin threads of the mesh that they're stuck in. It's going to do two things. It's going to bring the edges of the clot closer together. So think if you're like sewing up a hole, like if you have a rip in your clothes and you're sewing it up, when you pull the thread, what does it do? It pulls the rip sides of the material closer together, closing up that hole. It's exactly what this contractile proteins are going to do. So it brings the edge of the clot closer, and it's also going to remove any serum. So it's going to squeeze the cells that are caught in that fibrin mesh together, and it's kind of going to wring out any kind of fluid that has been stuck inside of the fibrin mesh. The fibrinolysis is a gradual degradation of the clot. Itself is going to be triggered by a series of reactions involving more clotting factors. So the main one here that we're going to see is that there is an inactive protein in your plasma called plasminogen. Plasminogen is going to be converted by some clotting factors into its active protein called plasmin. And it's ultimately going to be this plasmin that is going to slowly eat away at this fibrin clot as it is being replaced by new tissue. Now, there are some plasma anticoagulants that we have that, in addition to the inactive form of all these enzymes being in circulation and needing to be activated in order for blood clots to form, these anticoagulants are going to oppose improper coagulation or improper blood clot formation. The first one is called protein C system. This is a cluster of proteins that are inactive clotting factors. They're involved in the intrinsic pathway, and they are going to prevent improper clotting from occurring if there is not damage to the interior of the vessel. There is TFPI, tissue factor pathway inhibitor. This is going to inhibit the activation of clotting factors in the extrinsic pathway. If there's not true damage to the vessel, just damage to the tissues itself. Antithrombin is going to inactivate factor 10, and therefore it opposes the conversion of prothrombin to thrombin, which then would prevent the conversion of fibrinogen to fibrin. And then our cells also produce an anticoagulant called heparin. Heparin is a short-acting anticoagulant that also opposes prothrombin. And you may have heard of heparin. Heparin has been synthesized as a drug that is used and given to individuals who form blood clots improperly. Heparin is also, if you get an IV, you're normally given a little bit of heparin to keep the needle clear of any kind of clots. If you have serious clotting problems, you are normally given heparin injections. Of course, there's other anticoagulants that are given as medications, such as, well, very minor one would be aspirin. Aspirin interferes with some clotting factors, therefore preventing clot formation. There's also warfarin, which is a synthetic drug that's given to people to prevent clotting factors. A lot of these drugs are given to people who are at risk for heart attacks or stroke to prevent unwanted clots from occurring. Right, we're going to stop here. And the last one is going to be over blood types, which I did go a little bit over in class, but there's some things that I didn't go over. So I'll see you in a few.